Hey, welcome to Renew Education. This is an interesting little case here. It is a full arch on both sides, but what makes this interesting is I'm going to title this one Hidden Smoker Part 1. Part 1 is only because we're talking about the upper arch. I'm going to talk about the lower arch later. And the reason why I call it Hidden Smoker is I'm trying to be nice to not be so pissed off that this patient just flat out lied on his medical and dental history on does this patient smoke. So most dentists, I would assume, on medical dental history forums always ask that question because it affects the mouth so much. And he didn't show any signs of that. Not only that, he had been changing his clothes or changing his, something so that he didn't smell like smoke, because most smokers smell like smoke. So, long story short, implants were failing when I would go back and check on them or whatever. Maybe not all of them, but maybe one or two, and then another one would fail. And then I finally started smelling the smoke on this patient and asked him if he smoked. He said, "Oh, yes." And then I said, "I don't remember seeing that on your medical dental history." So on the medical history form, I go back into our copy of it, and of course he said, no, he does not smoke. So that really throws up the alarm because that is not somebody I feel like I want to work with anymore. The trust is kind of gone, and my goodwill goes out the door. Patients that are following this or maybe watching a case study like this is how we feel. Smokers tend to just wash it off and say, it's me, I'm great, they think they're super healers, it's not affecting anything, when they don't realize it affects everything. And I want to be successful as a physician. I know other doctors, they feel exactly the same way. A friend of mine's a cardiologist, and then he gets a smoker, and then he feels like he's doing stuff almost for nothing. You know, that's a very difficult spot for us as healthcare practitioners to want to be in, where you know this is just dooming that person anyway. You know, you kind of lose your will to want to do your best in a way, or you feel like, how is this going to be successful under these circumstances? Maybe patients don't understand that this is a biological event that needs to occur, and you're now compromising that biological event deliberately. So it's a really tough place to be. I don't like it, and I will talk about this guy's case because of that reason. I want to put that message out there. And please, if you have any medical condition, smoking or not smoking, anything, don't lie to the physician or the doctor trying to help you. It does not help you to do that, regardless. So, oh my gosh, I don't even know how I have to even say that, but I have to say that because this happens to us more than we like. So, let's talk about the case now. Let's look at the treatment assessment here. The treatment assessment would say that this guy is red because he's a smoker. But if we really look at the treatment assessments, you should really look at bite characteristics in this case and look at the orange bite classification, orange repeatable bite, orange on the vertical dimension or the VDO, orange on the chew pattern. I'm not giving reds, but posterior support. So this is where bite characteristics really come into play when you're dealing with a double arch case. And then you're looking at, for the sinus bone, that's an orange. You have light green for the constrictions, and the bone density is a yellow. It probably should be orange in some cases, because up here seems to be a little bit different on the bone density up here on the upper left side than the upper right side. What else do we have? The chew patterns, etc., etc. We talked about that. So anyway, let's get into this case. This case is a full arch case, even though there's 1, 2, 3, well, maybe not so good there, 4, that one's totally rotted, 5, 6 teeth, for sure extraction, full decay going on right here. So this is already kind of a loser case. You don't have very good bone around that either. So, for a patient to think about spending money on dentistry, you got to then now flip this away from single tooth type of work or dentistry. You got to get into the 4 implant, 6 implant cases, and let's see where we can find that. I always start where I think is the hardest to restore, and because the sinus looks like it's further up here for some reason and very low over here, that's kind of weird to see that. I want to start on that upper right side, and that dictates if I can do anything on the left side, because if I can't do much here on this right side, then you don't even follow up on the left side. So let's look at that and see if we get implants where we want them. So let's go into the mesial root of that upper first molar, because that's about where I want my implant anyway, and this is what it looks like. So it looks like there's some decent bone if we go across here. If we made a socket site and we did a graft, we're going to have a certain amount of bone. We have about 8 millimeters of bone. So I would put a 10 millimeter implant into this site. I wouldn't do an immediate placement, but I know I can actually save the bone and get a 5 by 10 millimeter implant and what I do are locator type of snap attachments. If you're a patient, you don't understand what a locator attachment is, just look up locator attachment denture on Google and you'll see what it basically is, and talk to your dentist about it. But this is a fine site. We know we can now work with this site. The bone density looks pretty good. And then the next site we want to look at would be something maybe right here for the next locator or the implant, or as far over as the canine too. So we could go over here too. Let's look at that. And now if we have that, then I think we're probably going to be pretty good. So once again, here, if you are going to be inclined to go into this area, you're going to want to graft it. You could do an immediate placement here. The roots are very short, but if you can't do much on the back one, sometimes I do immediate placements because I at least can get a denture piece on 3 implants, waiting for the 4 implants to heal. So that moves them along in a happier, better way with the intermediate denture that I could attach to it. So this is a case that you could do an immediate placement and you could get a benefit and you would add it there. So let's take a look at the site next door to it. So right here, let's see, if we went there, would that be even better? This is where the bone quality starts to lighten up a little bit, but this is another great spot. You can put the implant in, and then you don't have to worry about the immediate placement scenario where you have less success, maybe about 10% to 12% less success, according to literature. So with immediate placement. So you could do that there. So let's just put a little line. We'll put one there. We're going to put one, let's just say there. So now that has a higher level of success here. That one we're going to have to graft and let that heal. So if we're doing a 4 locator case, that means I want that to go over into the canine area here. So let's look at that. So that looks pretty good. You've got a good amount of bone. We can stay out of the nasal sinus pretty easily. It gets a little bit thin here. There's a little constrictive quality there. Let's just take a look at an implant. If we put an implant in, here is a 3/7. Let's put 3/7 by 10. That should be fine. It's going to get a little tight. So you're going to do a little compressive technique to kind of get that in there. If you want to go a little bit more distal, you could do that too. I would try to bury this one a little bit so I get away from that constrictive part right at the tip of the bone. But that's a quick one to place. And then you're looking at that first molar side again. So let's go back over here. And this is where it's kind of funny because we got so much sinus bone up there, we don't have to worry so much. So here's the question. Do you take this and do an immediate placement here? You could, because you can really drive that up. The only predictive value is what you got here, and that is the area right in front of that of that tooth. So is the bone going to be there in the end, or is it actually going to sag when you pull that tooth away, because you have no facial bone here, and then you got that lingual bone gone too from the palatal root, and then you go to this. So I would say graft this site, place the implant. I've done this quite a bit with the full denture with the palate. You can do implant, let that help secure the implant or the denture with those 2 implants. Doesn't put the implants in jeopardy as long as they're healed appropriately. So the second bone healing event is where you put the implant in here and here, and now you got a 4 implant case. If you want to go into a 6 implant case, that's great too, because we've got great bone in between these sites here. Maybe not on this side so much, it is still a little bit narrow, but you could get that 3-5 in there. And on the other side, you'd be looking at something right behind or right in between those 2, which looks like that. So it's a very similar kind of case. So this case should be a very, very good case. It should be a fun case. It was a fun case when I saw it, but turned a bit sour, like I said, how I started this video, because of the patient's dishonesty towards his own care. So that's it. We're going to talk about the lower in a second, so tune in for that. And once again, check us out on our other videos on our channel, as well as check us out on Facebook and some of our live broadcasts. So thank you very much. Cheers.